Working up early to come here. I'm actually really excited about this session. It's entitled Patient-Generated Data in the Clinic. And so how many of us have always wondered about going to the doctor? Most of your health happens outside of the clinical visit, right? And so they're only looking at data from such a short time, and now we can have a chance to close that loop. And I think that's what this session kind of looks at. The first three papers are in the clinical setting, looking at patient doctors, how they communicate, how they look at data, and kind of make sense of that. The last paper is looking at how care organizations, nonprofits, kind of take feedback from their clients essentially to improve the process and kind of the structural issues around that. So it's really a nice mix of papers, so I'm really excited about that. So presenting our first paper today, looking at the area of cognitive behavioral therapy for insomnia and how the practice around data and patients and doctors engage with that. Presenting today from Penn State, please welcome Haining Zhu.
Thank you. Thank you for the warm introduction. Hello, everyone. I am Haining Zhu from Penn State University, the College of Information Science and Technology. Special thanks to my advisor, Dr. Kyoung Choe. Without her, we cannot do this work. So everybody knows sleep is important. Everybody sleeps, and most of us spend approximately a third of our lifetimes sleeping. However, 30% of people in the States have insomnia, which is approximately 50 to 70 million of Americans. For people who are older than 65, this number increased to 50%. 10% of general population has a chronic insomnia disorder, which means insomnia occurs 3 times per week for at least 3 months. Approximately 95% of Americans experience insomnia during their lifetimes. Sleep problems hinders overall well-being and work performance. Every year, hundreds of billions of dollars are lost because of the direct and indirect medical expenses, such as accidents or productivity loss. So, sleep is important. What are the available treatments? There are 3 current treatment options for insomnia. Medical treatment include prescriptions and over-the-counter medications, alternative medicines such as herbal tea or acupuncture, and non-medical treatment for insomnia like cognitive behavior therapy. Cognitive behavioral therapy, the acronym is CBT, is based on the idea that how we think, how we feel, and how we act are all interconnected. Specifically, our thought determines how we feel feelings and how we behave. There are lots of study has been done to use the CBT treatment to treat mental illnesses in both the CHI community and medical field. Our work is specifically focused on CBT for insomnia. From now on, I will refer cognitive behavior therapy for insomnia as CBTI. So CBTI is a structured program based on CBT. Through cognitive and behavioral techniques, CBTI helps patients identify and overcome the underlying causes of their sleep problems. Compared to the sleeping pills, CBTI have fewer known side effects and long-lasting effects. So CBTI is a great way to treat insomnia. So what are the current available ways to provide CBTI? Currently, we have mainly 2 ways to provide CBTI. One is InPerson CBTI, which is provided with a doctor, and the other is CBTI, which stands for computerized CBTI. On the one end of the spectrum, we have a human doctor, such as a sleep specialist, to provide in-person CBTI. The advantages for this human-human interaction are that patients often have higher motivation and thus higher adherence rates to the CBTI program. However, as we mentioned in the prior slides, 50 to 70 million of Americans has been affected by insomnia, and there are only 300 certificated CBTI providers worldwide, so which limits the treatment accessibility. CBTI treatment is delivered over a course of 5 to 8 individual therapy with extensive effort from both clinicians and patients. Therefore, the scalability and efficiency of the delivery mechanism is limited. Moreover, in-person CBTI is very expensive and time-consuming. So on the other end of the spectrum, we have the option of all CBTI being provided by computer systems. CBTI which implies that there is no human involvement. Patients who opt to computerize the CBTI need to be accountable to themselves. This option requires high self-control to stick to the CBTI instructions and to make the therapy work. The advantages for computerized CBTI are that more people can get CBTI treatment in the more locations, and it is much more cheaper than in-person CBTI. The major disadvantages is that computerized CBTI programs have higher dropout rate and low adherence rate. Patients who participated in the computerized CBTI often disappeared after their initial session, and we don't know why. So both ways to provide CBTI has pros and cons. A better way to provide CBTI might be to combine the in-person CBTI and the computerized CBTI. So there are a hand of CBTI technology available to provide this hybrid practice, such as CBTI Coach, CBTI for Insomnia, SIGCHI, and Restore. But there is a lack of research on this approach. We do not know how to design effective hybrid CBTI technology to address the mundane tasks of the CBTI, and also to preserve the important patient-clinician interaction. Thus, we ask the following research questions. What is the role of a human doctor in the CBTI context? And how can we effectively design a hybrid approach for CBTI? We think in order to encourage technology adoption in CBTI practice, designers should find a way to how best to combine the CBTI clinicians' involvement and technologies to provide quality care. To answer those research questions, we decided to do a study to understand the CBTI clinical workflow. In addition, we did semi-structured interviews with patients and clinicians to understand their barriers and enablers associated with CBTI practice. We observed the 11 CBTI sessions at the Sleep Research and Treatment Center at Hershey Medical Center. We observed 9 initial sessions and 2 return sessions from those 9 patients. For each observational session, the observer sat in the corner of the exam room and took detailed notes of the patient-clinician interaction and treatment process. Due to the sensitive nature of the conversation, we did not record any audios. After the observation, we conducted semi-structured interview with total 17 participants. The inclusion criteria for a clinician was that they have to have some experience in providing CBTI. 10 clinicians was found from word-of-mouth referrals and from the American Board of Sleep Medicine website. The 7 patients we interviewed were the same patient from the observational studies. So we interviewed 14 participants via phone and 2 via Skype and 1 in person. The duration of our interview ranged from 40 to 80 minutes. We then utilized the semantic analysis to analyze our data. All of the interviews are audio recorded and transcribed to facilitate analysis. I will talk about our result and discussion in the following sessions. So the list here is how we organize the paper for the result and discussion session. But for the interest of time, I will bring on the discussion topics while introducing our result of the clinical workflow. Most of the CBTI workflow involve 5 high-level activities: patient in-home activity, information seeking, information sharing, information assessment, and documentation. Existing clinical workflow model usually only examine the clinician's perspective, but in CBTI, the patient's role is equally important. Without patient's input, clinicians cannot give or adjust to any prescriptions. One of the contributions we made in this study is the inclusion of the patient's role in the clinical workflow. This trend in which patients seeking more active role in their healthcare will likely become more prevalent in the future, especially where patients are more empowered by technology. So here is the breakdown of the current clinical workflow of the new patient. The initial visit lasts 2 hours. There are 2 rooms. Above the dotted line is the exam room, and below is the clinician's office. There are 3 people involved. The red represents clinician and yellow is assistant, blue is the patient. As we can see, in the first 30 to 60 minutes, the patient starts the consultation with a screening survey, and the assistant stays in the exam room to answer the patient's questions. This is because the question presented on the survey often confuse new patients, so the assistant must be there to elevate the confusion. In the following 10 to 15 minutes, the patient is awaiting alone in the exam room while assistant goes back to her office to score the survey data. In the next 30 to 60 minutes, the patient once again is left alone to do another pre-treatment assessment survey. The assistant is occasionally come to the exam room to check up the patient's progress. After completion, the patient waits another 15 to 20 minutes alone for the clinician to score and evaluate the survey. After that, in the remaining time, a patient finally has the opportunity to talk to the clinician. Then after the patient leaves, clinician will document the whole visit. So the current workflow impeded patient-clinician interaction and collaboration. The clinician spent about 30 minutes during the visit digitizing data from paper-based surveys. This encompasses much of patient's visit time and can lead to data transfer error. Moreover, patient only receive a clinician's verbal assessment, as the clinician usually does not share the digitized data. Patient 8 said, I don't think I actually did see the graph. It was there on his computer. I was listening to his interpretations of it. So this is both a challenge for in-person and low-tech CBTI, and an opportunity for technology to address. Here is the workflow when a clinician sees a return patient. Visit for a return patient lasts usually 1 hour. But before the patient can go back to the return visit, he or she needs to record sleep for at least 2 weeks and bring a sleep diary to the visit. So this is a copy of an actual sleep diary brought into a visit. It recorded a patient's sleep, awake time, and sleep disturbances. Clinicians use data from the sleep diary to calculate sleep efficiency, identify sleep patterns, and reveal how specific factor affects a patient's chance for a good night's sleep. Therefore, sleep diary is arguably the most important component for a therapist to identify how to best treat patients' insomnia. The return visit started with a 5-minute short assessment survey, and upon completion, the clinicians scored the survey and the previous sleep diary in their office. This is followed by in-person communication with approximately 20 minutes of the discussion of the previous sleep condition and approximately 30 minutes to adjust the new prescription and the sleep education for the next session. After a patient leaves, a clinician will document the whole visit. This portion of the workflow allows for greater interaction, but it could still be improved. Following the sleep prescription while patients are discharged at home can be extremely hard and requires lots of self-control. It is one of the reasons why in-person consultation is preferred over computerized CBTI. Many clinicians utilize motivational strategies during the information sharing and education phase to help patients keep engaged with the program. Patient 1 said, "It's educating me to think differently and to identify triggers that might be inhibiting my sleep. There were relaxation techniques and things like that. Try to turn off those negative thoughts and worry before bed. Try to let things go. A lot of education about that." No 2 patients will have the same motivational level and ability to benefit from computerized CBTI. Patients need strong motivation, confidence, willingness, and capability to learn and act upon the CBTI menu instructions to promote CBTI efficacy. We envision that a decision support system could help clinicians to identify which return patient will be able to benefit from the computerized CBTI with occasional supervision, and which will require in-person CBTI. Our work can guide the exploration of where and how technology can be used in conjunction with clinician input to promote personalized treatment. Although some researchers suggest that technology can allow for automated personalization, our work suggests it may not yet be able to address patients' need without clinicians' input. For example, patients with comorbidities. As clinician 7 noticed, a certain numbers of people that I see are probably suffering from a more generalized anxiety disorder. Some of them may have depressional problems. Part of what I'm doing is trying to rule out other possibilities or at least to understand sleep problems in the context of large difficulty. In most scenarios, either technology or in-person CBTI is used, but they are not currently widely being used at the same time. Therefore, utilizing technology in conjunction with in-person CBTI and determining how best to integrate technology with in-person CBTI will require further research. This integration will create more opportunities for clinicians to personalize treatment and engage with patient, as well as lower the tracking difficulty. Technology cannot address every problem in CBTI now, but it can be used to make CBTI more efficient and effective. By understanding the clinical workflow, we see that many space existed for technology to assist the patient and clinician in building the quality therapeutic relationships. Our work can guide exploration of how to design effective hybrid CBTI technology to address the mundane tasks and to preserve the important human-human interaction. Thank you.
Hi, my name's Neil Davidson. I'm a paediatric doctor working in Newcastle upon Tyne. Thank you for a very clear, lovely presentation. 2 quick questions. One, it's interesting to see how much time the American healthcare system devotes to this, whereas in primary care in the UK, a GP would have 10 minutes to do a sleep consultation, or a psychologist might spend half an hour with a patient. And I'm wondering how you think technology could shorten the American workflow. And the second question is, what sort of sleep tracking technology, or how do you think sleep tracking technology could fit into this with things like patient diaries?
So the first question is how technology to short this clinical workflow. There are many, like from our participant, there are many people mentioned that because the time is, even though they have 2-hour visit, there are still lack of time to analyze their data. So what clinicians will do is just look at those sleep diaries and estimate it. So instead of actually putting them in an Excel sheet and calculate, they still just estimate. So for us, is like if the clinician can having all those survey data before the visit, it will drastically reduce the new patient clinical workflow. Yes, and the second question is
thinking about patient-recorded sleep diaries versus tracking technology.
Okay, so yeah, for that. So tracking technology include like purely automated, which is many people will prefer. But from our understanding or from the study, it's like with automated technology, even we provide lots of detailed feedback, patients actually don't have the reflection process. So they just know it's there and they don't look at it, or they look at it, they don't think about it. But for manual login, people, because it requires extra step to put in the numbers in, it actually helps them to reflect and they will look at data. But however, it will create lots of tracking burden. So we are thinking about semi-automated tracking technology for this.
Thank you very much.
Thank you.
Hi, it's Gavin Doherty from Trinity College Dublin. Really like to talk. I note in the paper you dwell on this issue of engaging less motivated patients. So obviously time in the clinic is always going to be limited. So how would you see this informing things that between consultations?